Hi everyone, my name is Lennie Derde. I work as an intensivist and clinical researcher at the University Medical Center in Utrecht, and the title of my talk is When Uncertain, the Best Option is an RCT. This session consists of 3 presentations on the subject, of which this is the first, and I'm going to try and take you through my thoughts on this in about 10 minutes, hoping to make the point that there are RCTs with some novel design features that may be better suited in some circumstances than conventional RCTs. But first, let's talk about what uncertain. So this may sound very obvious, but sometimes we are not uncertain. If we think about jumping out of an airplane with or without a parachute, I think we're all pretty convinced wearing a parachute is the better option. And if there's such a high probability that something will work or will not work, we don't need an RCT. And that may sound like an open door, but I do think it's important that we save RCTs for important and relevant clinical questions. So that's always the first thing we have to think about. So sometimes we are super uncertain. For instance, in a new disease, we can't just do RCTs of new therapies. It starts with different type of research. We need to be able to confirm the disease. So you will remember this from when COVID-19 first entered our lives. We need to know the pathophysiology. We need to have ways of identifying promising drugs. And for this, we need a whole range of study types. And RCTs are not the solution for everything. They're part of a whole, I'd call it, portfolio of research. And I think we'd actually probably be better off if we also thought and designed research in these kind of portfolios. And the other aspect, but I'll touch upon that later, is that in new diseases like we had in the COVID pandemic, RCTs may not be flexible enough to help us find answers quickly. And then let's say we have the right type of uncertainty, and we have this patient with a disease, and we have, standard of care versus a new therapy or two therapies that we want to compare, so comparative effectiveness studies. This is the type of question that can be answered by a conventional RCT. And the first modern day RCT was conducted in 1948 when doctors compared streptomycin to bed rest in a patient with tuberculous pneumonia. But today, it's not about streptomycin versus nothing. If your patient is admitted to a hospital, and I work in the ICU environment, so it's even kind of worse there. If a patient's admitted, they don't get, one treatment or nothing, or, a comparison between two treatments. They get a whole range of treatments at the same time. They get multiple therapies. They get a whole regimen of treatments at the same time. So the question is, how do RCTs handle that? All right, so with that, forward to 2020. Because as I just referred to in a couple of slides ago, in a pandemic, learning through RCTs gets even more complicated. So if you think about how doctors act in a pandemic, and I think Derek Angus has really elegantly written this down in JAMA 2020, some doctors just say, just give the treatment, even if there's still uncertainty, whether it's effective or not. I just want to do something for my patient. I want to help them. Others may say, no, first do no harm. We have to learn about these treatments. We have to find out. This is currently framed as a choice of approaches. You either do something, you treat the patient, or you learn something, you test the drug. But usually the best option here is to kind of fight the common enemy, to team up, to blend both approaches, to try and learn while you do, to have the best outcomes for your patient. So I don't think this should be framed as opposing views. I think we should try and blend learning and doing. I'm saying that because there are major challenges to learning in a pandemic. So first of all, clinicians really experience distress if they don't give a treatment that they feel may work, even if the evidence is uncertain. They feel the responsibility to do all they can for their patient now. And the benefits of learning about the best treatment for all patients, as well as the delay in knowledge generation if they don't randomize this patient in a trial, they are felt less so. They're more abstract, more remote. The first kind of priority is this patient. So secondly, RCTs can be a real pain, right? Anyone who's ever done an RCT knows it takes a long time, a lot of effort and funding to set up and execute a trial. And even if a trial is live, it's still much easier to just order, let's say, hydroxychloroquine than to go through the steps of randomizing between this drug and placebo or this drug and standard of care. And during surges of patients, valuable time to learn by including patients in trials is thus lost. Lastly, in a pandemic, and we've seen this in the current pandemic for COVID-19, the research enterprise doesn't really come up with a unified plan. There's what we call academic cannibalism. Thousands of trials are set up, and groups are competing for funds. And that means that hospitals are approached to participate in vast numbers of trials, and there's a bit of chaos, and nobody knows what's the most important thing to investigate. And I think a novel type of randomized controlled trials called adaptive platform trials, which occur in lots of variants, can help bridge these gaps. So adaptive platform trials are a subset of randomized controlled trials. They use randomization, but they have two extra characteristics. So first of all, they use master protocols or a core protocol that allows several interventions to be investigated at the same time, meaning patients are included in kind of multiple study domains at the same time. And the second aspect is that they are adaptive. So the design is such that we learn during the course of the trial, and the trial adapts based on the data that accrue in the trial. So let me try and explain further. So this is the traditional situation where if you would take COVID-19 as an example, and you'd want to investigate whether immune modulation works or antivirals work or anticoagulation strategies, which is the best, you'd have to do 3 trials, setting them up all separately and in series. So what if you'd look from the disease and you would say that these are all treatments that the patient may need, and that you would randomize the patient for each of these, what we call domains, at the same time. The patient could then be randomized within each of these pillars of the study, of the domains of the study, and will get a regimen of intervention. So in this case, the patient receives CAA. So then the adaptive features. So what adaptive trials do is they pre-specify finish lines for superiority and inferiority of interventions. And they can stop an intervention as soon as it passes the pre-specified threshold, not sooner, not later, also preventing inconclusive trials. And that allows us to quickly discontinue poorly performing therapies. And that may be very reassuring to clinicians, because they will want to know that the assigned recipe for each patient will be increasingly likely to be superior as the knowledge accrues in the trial. So this is kind of the trial learning as it goes. Learning aspect, sorry. And another advantage of investigating multiple therapies on the same platform is that we don't lose time weighing all the pros and cons of each therapy to try and choose the most promising one if we can only investigate one. And I think that's important, because this pandemic has taught, if it has taught us anything, is that we can be surprised about what works and what doesn't. And we have to have a continuous pipeline of promising drugs that we investigate. So adaptive platform trials are a one-stop shop. A last advantage of these type of trials, and actually all RCTs, is that in a rapidly changing pandemic, perfection will be the enemy of the good. So if you want to build the perfect cathedral, it will take you a long time before you can use it. And in trials, that means, for instance, the use of a placebo can increase trial rigor, but is not necessarily crucial depending on your outcome. And it will add logistical burden, hampering the study design, especially if you have multiple interventions to launch with a difficult to produce placebo or difficult in shipping it across borders, and it will also make the execution of the trial more difficult. So, in summary, to get back to the title, when uncertain, the best option is an RCT. I think, when there's the right amount of uncertainty, the best option can be an RCT, but it should be embedded in a research portfolio. And novel options for doing RCTs have arisen. I think the adaptive platform trial is an example of that. I'd like to thank you for your attention, and I'd be happy to take any questions.